So we have our next speaker. I think this house need no introduction. Dr. Ranjith is the consultant urologist from Jumeirah Medical Clinic from Dubai, and so the expert in male infertility and sexual dysfunction.
Surgical manager.
And best thing I will say that published more than 500 peer-reviewed manuscript. This is the, I think, the best CV for sir. Thank you.
Thank you very much, yes. The most important thing that was mentioned in Dr. Tejas's talk, which goes with what Dr. Rupin mentioned, you saw that first sperm analysis report, he showed low volume, acidic pH, negative fructose, right? And you saw azoospermia. That 95% of the time is vas aplasia. And that can only be determined with Dr. Rupin's hands, not with a scrotal ultrasound. Okay, very important. I have seen patients like that being given Clomid, 25 milligram, 50 milligram, gonadotropins, FSH, HCG, not Fort Plus, not Oligocare Fort Plus, other antioxidants, useless, right? Vas aplasia, CBAVD, you cannot conceive naturally, you have to proceed with sperm retrieval IVF. So physical exam there was so important, but got passed from one gynecologist to the other with multiple investigations and multiple hormonal therapies, and spent enough money for a whole IVF cycle, and then came to me only to find out that he didn't have VAS. Right? So physical exam, critically important. Please do not substitute that with hormonal therapy, gonadotropins, or scrotal ultrasounds, which will never detect absent vas deferens. What surgeries are we going to do? How many people here do surgeries for sperm retrieval? Show of hands. Okay, at least 50 to 60% of the audience. Okay, good. Okay, so it's a relevant talk. Please do not do PISA for production defect. You know how everybody mentions, the urologists are clapping. It's just a very common thing here in India. Oh, do you do TISA, PISA, microtesy? It's just all three words get together like a word salad, like the salad outside. Oh, do you do TISA, PISA only, or do you do microtesy as well? Please remember, epididymal obstruction, obstructive azoospermia, you can have PISA. If the patient has small testis, high FSH, and it's azoospermia due to a production defect, please do not do a PISA. You will not get any sperm in patients with production issues. If you haven't learned anything, please remember that there is a difference between a TISA and a PISA. One is used for production and obstruction. You can do TISA for both, but PISA can only be done if you have an obstruction defect. Just remember that. So we'll proceed with varicocele repair. I think you can play I don't have a computer with me. IT guys? Hello? Hi. Hey, they're talking. Can you hit play? And without the audio. Is it playing? Okay, it's playing. Excellent. So this is the microsurgical subinguinal approach that Dr. Rupin was talking about. This is a 3 centimeter incision that is made above the external inguinal ring. And you go through this carpus fascia, and then I use a Babcock clamp and my finger, and the only structure, as long as you're holding up the external ring, should be the spermatic cord. So you deliver the spermatic cord, people think we discussed the comparison with laparoscopic surgery, and it's a fairly easy way to deliver the spermatic cord in this nice 3 centimeter incision. The goal of a varicocele repair is to basically identify the artery, the vein, and the lymphatic. I think those are the 3 principles. The first step is to try and see if you can identify the artery. Rupin showed a very nice picture showing how small the artery is compared to the vein. You'll see it actually in this picture, in this video as well, as to how small the artery is. I use a microdoppler routinely to identify not just the location, but also to confirm that what I have is the artery. Here, what you see is a very nice big blue vein. And this is a vein. It's very easy. You can see it with your naked eye. You don't need a microscope for this. But when you do need a microscope, the goal is to basically try to see if you can identify the artery or not. And so we use a microdoppler to basically locate the artery. And as long as you have a Doppler pulse, you should be able to isolate and dissect the artery. And here you do find the artery here. Sometimes it'll pulsate, sometimes it won't. And this is a vein which will not pulsate. You see how big the vein is compared to the artery. And this is just a nice vein. Usually I use double ties. If it is around the artery, I don't like to use clips right around the artery. If the veins are pretty far from the artery, I just use clips because I'm not concerned that the clips will touch the artery. This is the artery. You see how the vein is right next to the artery, and you want to try and spare the artery. In people who do open surgery, this is my biggest concern. I think there's a pretty high chance because the artery is so small, you would just basically tie off the artery along with the rest of the veins. And so you want to preserve the artery. So we talked about what you want to preserve. You want to preserve the artery, you want to preserve the lymphatics, and you want to basically tie off the veins with this approach. And fairly easy, you identify the vas. You want to make sure if there are any external cremasteric veins like that, then if they are far from the artery, obviously I use clips as well, and that's not such a big issue, and you basically cut off the veins. And at the end of the day, all that you want to preserve is lymphatics, you want to preserve the artery, and you want to tie off all of the veins at the end. Now let's move on to azoospermia. So azoospermia, so what all approaches can you do? You can do fine needle aspiration, you could do percutaneous biopsy, you could do single seminiferous tubule technique. There's a video from Dr. Rupin that I will show. And we can move from basically the least invasive procedure, which is the TISA, to all the way to a microtesi. So how many of you do TISAs in your office? Show of hands. Okay, quite a few. So how do you start off with a cord block, right? So with 2 fingers, you pinch the vas, and this is a patient who is awake, and this is a 25 gauge needle. I use 5 cc of lidocaine and 5 cc of bupivacaine, and you basically infiltrate the cord directly perpendicular. A lot of people do the dance of moving the needle this way and that way and trying to think that they infiltrate the cord even more. You don't. You don't have to keep doing the dance. As long as you have the vas between your 2 fingers, you infiltrate directly perpendicular to the cord. And if you know you got the vas, most of the nerves supplying the testis, 70% of them surround the vas. So as long as you infiltrate the vas very well, you know you've got a very good cord block. And then you can do a little bit on the skin as well if you're doing it. TISA, this is an 18 gauge needle. And use a suction apparatus, but if you don't have a suction apparatus, as long as you have suction is totally fine. Again, here, you don't need to go to multiple places, you don't need to do a dance. It is a simple in and out approach. As long as you're using a simple in and out approach, I know Rupin uses the butterfly needle, also totally fine. But remember, it's in one place. You don't want to go multiple places because you risk having an intratesticular hematoma leading to a loss of the testis. It has happened with TISA. I've dealt with legal cases that have done that. It is not a simple procedure. People think, oh, it's a simple TISA, simple TISA. It's a blind procedure. You have no idea if you're poking into the blood vessels or not, and if you're creating an intratesticular hematoma or not. Single seminiferous tubules mapping, obviously we will hear Rupin's thoughts on this. This is Dr. Rupin's video. And basically this is a mapping approach that was initially started off by Paul Turek, but all credit to Dr. Rupin to make this a therapeutic approach. We learned from Dr. Tejas's talk that we shouldn't just be doing this for diagnostic approaches anymore. And the goal is to basically make a single puncture opening, hopefully in multiple places through the testis, but to try and extract tubules with forceps through that. If you don't have the ability to do general anesthesia, don't have the ability to do microscope, don't have the skill set to do microtesi, then this is much better than doing a simple blinded TISA, because at least here you have the satisfaction that you have mapped all areas of the testis in a systematic fashion, and you've obtained small tubules that you can pass off to the lab and have a better approach than just having a simple needle biopsy in one place of the testis. And so this is one approach. We'll talk a little bit today now about microtesi. There's enough discussion. Show of hands, how many people do microtesi in the audience? All right, less than 5%. Excellent. So what is the principle of microtesi? So the goal is to bivalve the testis and use a microscope to be able to see different areas within the testis. And the goal is to try to see if you can advance to 37 seconds IT. They're very busy here these days. Guys, advance to 37 seconds. 37, yes. So the goal is to basically identify tubular differences. Always ask me, anybody can correct me if you can, but the goal is to basically see if you can tell tubule differences. Can you fast forward to 37 seconds, please? Tubule differences between a large tubule versus big tubule. tubule that is filled with fluid, tubule that is not filled with fluid, tubule that is opaque, tubule that is not opaque. And that is the most important principle in microtesy. Do you not understand? You can. Okay, sounds good. No problem. Hopefully we'll just wait and it'll get to the 37-second mark. But the goal, that is the goal. Anybody always says, oh, microtesy, I'm able to see tubules that are different, tubules that are bigger, tubules that are smaller. I can tell tubules with sperm, without sperm. I think they're making it up. And after all these years and after publishing as many papers as I have on microtesy, I think I can be fairly certain that we are not very good and not very trained at telling tubules with sperm, without sperm. But I think we, with human eyes and enough experience, have determined tubules that are different. If the tubules look different, that's excellent. Most of the time, tubules are fairly uniform. Like, for example, here, you bring in the microscope, and all you're seeing is tubules that look just like each other. If you pick up these tubules, it's only extra lab for Dr. Shmuri and his team to search through tissue that you know has no chance of finding sperm. So just doing random biopsies and giving just tubules from different places, you can, if that is a desperation approach. But if you give less tissue to the lab and pick up only tubules that are bigger compared to smaller, then at least you have a much better chance of that the lab will find sperm, right? Finding tubules and sending tissue from the OT, I think that's only 50% of the battle. Having a good lab, we'll hear a very good talk from Dr. Shmuri about finding rare sperm after this. I think that is half the battle. I wish I could tell you every microtesy looks like this, right? So you see majority of the tubules are flat, uniform, do not look good, likely have a very low chance of finding sperm. But this nice one cluster here that is very big, everybody can pick up this big tubule, and hopefully, these tubules, when you do see pictures like these, will have sperm. If you read most of the papers on microtesy, you will all think that all microtesies look like this. For the few people in the audience that do it, will all attest to you that most cases do not look like this. I think 20% of the time we find these big tubules, we get super happy. We tell the lab, oh my gosh, this is definitely going to be sperm. I sent it in a separate Eppendorf tube, separate dish. Please start with that sample because that I know has a very high chance of finding sperm. Majority of the time, tubules will look uniform and will not appear to be different. And so you should just train yourself that that's what the difference is. Hopefully in the future, Dr. Shmuri, we are collaborating with a company from Australia. Dr. Rupin made the connection because he met them at a conference. Lab will have AI to be able to identify those rare sperm. Right now, he will tell you most labs spend 2 to 3 hours searching for sperm. If you don't have donor as an option, and this is your last chance to do an IVF cycle, you have to put in the effort to find those rare sperm. Many stories that most people will tell you, we found that one sperm 4 hours later that became a biological child. So you do have to have a very good lab. This is not for the labs that do 10 retrievals in a day and have one embryologist search for 15 minutes and call you back and say no sperm was found, right? So if you're truly doing microtesy, you've invested the time, effort, and money, you have to make sure that the lab is also on board. Nice algorithm that Dr. Rupin and I and Hussein Kandil at Abu Dhabi basically diagnosed. So I think if you start off, I used to be microtesy for all. I think this is sort of a good approach. In patients who have normal semen pH, normal semen volume, likely evidence of obstruction, a simple needle tesy is a good idea. You don't need to take them for fancy procedures. If you don't find sperm in this cohort, then you can think about using an SST mapping. Likely this is maturation arrest. All tubules will look uniform. Using that, I think, is a good idea before you think about proceeding with a microtesy. In a small testis where FSH is greater than 5, testis volume is less than 10 cc. Small testis where difficult to even do SST mapping because the testis is very small, Klinefelter syndrome, cryptorchidism, and so on, you should directly proceed with microtesy. So I think this is a nice approach for patients with azoospermia. If you have the ability to do all of these sperm retrieval approaches, I think this is a good algorithm to follow to try and triage patients for the best sperm retrieval approach, for the least invasive sperm retrieval approach that can yield the best chances of finding sperm. I think intra-op imaging is the future. There's now, Leica has a new microscope with OCT technology which will be able to tell you tubules with and without sperm. We are moving in the future. this whole concept of subjective, oh, does this have sperm? Does this not have sperm? Let's take it out. Let's not take it out. Let's send it to the lab. Let's keep it here. Let's send it to biopsy. I think in 5 to 10 years, there will be advances intra-op that will be able to tell sperm versus no sperm. But so happy that Rupin's now here in Dubai with us, so happy that Akshmuri is also here, but what a wonderful place to collaborate and try to advance this field of non-obstructive azoospermia, where so many patients still suffer and we still don't have so many answers on why some tubules make sperm, some don't, why some people make sperm, some don't, who has sperm, who doesn't, who has sperm in the lab that you don't find in the OR. Just too many questions to be answered. Despite the fact that we know so much, I still feel that huge box of non-obstructive azoospermia patients are not cared for. But very happy to be here, and hopefully we'll take questions later on. Thank you.
Yeah, thank you, sir. We'll take the questions after the last talk, I think. Yeah.